All right, I'm going to talk about lung masses and as advertised, and just let the talk kind of wash over you. It's laden with lots of details. Don't sweat them all. 8 to 12% retention would be the goal. All right, let's start things off with 5 unknown cases. Just pass your eyes over these. Good. Not going to give you a lot of time. Number 3, case from my neck of the woods, mostly at San Francisco General Hospital, if that's a clue for you. Number 4 is not a subtle finding. All right, number 5. So here's how I want to structure this. We're going to talk about an approach, my approach to a lung mass, how I break things down, and sort of 2 common scenarios where lung masses or lung nodules present themselves, and a little bit of details on biopsy, some of the initial index card worth of facts on biopsy. And then getting into lung cancer a little bit more specifically, cover the subtypes, and no kind of comprehensive treatment of lung cancer staging, but only some of the key breakpoints and some of the differences between the 97 staging and the 2009 staging, so you have some of that stuff. A lot of it is in the notes for reference, but I'll cover what I think are the relevant highlights. And then, not lung cancer. This is how my brain works. If it's a big white blotch in the lung, it's either lung cancer or not lung cancer, and that breaks down into some other categories that I'll run through. And by the end, you'll be fairly exhausted by lists of differentials, but again, 8 to 12%. All right, so just some definitions. Up to and including 3 centimeters, we call it a nodule, otherwise a mass. And it has the standard features that we describe with every mass, borders and size. Size and growth being the most important things if you have a prior. But if you're trying to declare something benign on a one-shot deal, what you're most interested in are fat, whether or not the nodule or mass contains fat or calcium, and specifically whether there's a benign pattern of calcification. And this is familiar, but for review, there are 3 sort of symmetric patterns of benign calcification and one other one that makes something benign on first glance. So the whole thing can be calced. You can have central calcification or concentric or peripheral sort of target calcification. All 3 of those patterns, I think of them as the symmetric ones, they all basically mean old granulomatous disease. And the 4th pattern is a hamartoma, right? That's popcorn calc, and that's characteristic of a hamartoma. But you have to have a nodule of a certain size to have enough real estate to declare there to be popcorn calcifications. And this one, like most hamartomas, is smiling. Okay, so what about this thing? On initial glance, it's pretty ugly, large, spiculated, got some emphysema next to it. It has a central calcification, so benign, no follow-up needed. Next case. No. It's a lung cancer that ate a granuloma or did something or has some dystrophic calcification. So, it's good to lay out a rule and then immediately violate the rule. You're welcome. I'm sure that's really settling and puts you at ease at this stage of the game. But, if something looks nasty and malignant, just stick with nasty and malignant and worry about the calcium later. This thing is looking lobular and smooth, and perhaps it's been there a while. And although lobulated margins are sort of reassuring and do have they reduce the likelihood that something's malignant, they don't do it enough to hang your hat on that. But when you look at it on soft tissue windows, interrogate it with Hounsfield units, it's got fat density. This is benign. By definition, it's a hamartoma. It's a leave it alone type of lung nodule. So 2 common scenarios where lung masses or nodules present themselves. One is a good old solitary pulmonary nodule. This is the chest equivalent of something that's too small to characterize. I know it's been a long time since they talked to you about livers or thyroids, and you were missing the too small to characterize hedge, so I thought I would bring it back for the final day. There it is, too small to characterize. What do we do when we encounter this? We try to characterize it. How big is it? Has it grown? Just like I said. And we have the usual arsenal of options for doing something about it, including more CT scans, sometimes PET or getting tissue. Really, it comes down to size as the most important single parameter for determining whether something's likely to be a primary lung cancer. And it kind of breaks down like this. Less than 4 millimeters is very unlikely to be malignant. Greater than 8 millimeters is likely enough to be malignant that you should probably do something definitive about it besides get more CT scans, such as biopsy, cutting it out, or maybe getting a PET scan. And in between, we leave it up to, Fleischner guidelines, consensus guidelines that say sort of stratify patients by risk factors for lung cancer, high and low risk, and prescribe a series of follow-up CTs with set intervals accordingly to try to document, usually to try to document 2 years of stability. But remember, Fleischner Society guidelines are for patients. This is not follow-up metastatic cancer. This is no known cancer. What is the likelihood that this nodule represents a primary lung cancer? Scenario 2 is on the other end of the spectrum, right? We got a lot of abnormality in these lungs. This is too large to characterize. I don't know what's going on here. Something's bad is happening. We know maybe from clinical information that there's a high suspicion for cancer, but the whole left lung is whited out and the right apex doesn't look so hot either. In this case, you throw them in the CT scanner, you get the same kind of answer. Everything looks bad, too large to characterize. The question comes up, where's the cancer? We're going to try to advance this question. We're going to put a needle someplace. Got to know what's going on and where. And I use the following parameters. Is something enhancing differently than the rest, either more enhancing or less enhancing? Is something exerting mass effect on structures that don't like to get pushed around, like airways with cartilage in them, arteries with muscle in their walls? Fissures is a less perfect rule. Things violate fissures all the time, but cancers will do it with reckless abandon. And if you have a PET scan, is there, amidst what will no doubt be a background of hypermetabolism, is there a single glowing orb that you're going to put a needle in to try to get to the answer? So I think with the help of that orange thing, I can try to convince you that there's a little differential enhancement. It's mostly an optical illusion, but I'm just going to try to bluff you into believing that it's there. This differential enhancement points to the cancer. I think it's an easier sell for me to make that all of these airways are blocked up centrally because of the central cancer. And in fact, on the axial image, you get this sort of tip of the iceberg phenomenon that's going to direct the bronchoscopy, in this case, towards the diagnosis. And in this case, we had tuberculosis on the right and small cell lung cancer on the left. But that was ultimately made via bronchoscopic biopsy with an assist from the radiologist. I wouldn't want to avoid taking some credit for that particular case. Here's another case. It's a different patient with a diffuse abnormality, some ground glass opacity. Same question though, where amidst this problem is the cancer? And in this case, the PET scan comes in handy because the PET scan has this focal ring of hypermetabolism on whatever background of low-grade uptake there is, that when you overlay it with the CT, basically tells you this is your hypermetabolic biopsy target, and that ended up being an adenocarcinoma. Speaking of biopsy, if you should find yourself in a real or artificial situation discussing the ins and outs of biopsy, you might describe your approach as follows. The first thing you do is do your due diligence with respect to the indication and the priors and the labs and the consent and having the relevant conversations with the referring doctors. And then in the conversation with the patient, it'd be worthwhile to have a few numbers at your fingertips regarding complications. Of course, the biggest complication, the most specific one is pneumothorax, and it happens, some sliver of air happens outside that lung probably 20 or 30% of the time. Some smaller percentage of all comers end up getting a chest tube and having to stay in the hospital for a longer period of time. A lot of patients will cough up blood, a decent number, and some will start coughing up as you're doing the biopsy. Dreaded complications like air embolism are much, much more rare, and death gets mentioned or it's on the form, but it's also very rare. I also consent people for the possibility of a non-diagnostic biopsy because sort of a different kind of complication, but worth at least raising that so that if it happens that way, somebody once mentioned it to them. All right, lung cancer, moving on. Breaking down the subtypes of lung cancer, probably about half of all lung cancers are either adenocarcinoma or adenocarcinoma spectrum lesions, formerly known as bronchoalveolar cell carcinoma. Squamous cell cancer, maybe about a quarter. Small cell cancer makes up most of the rest of the lung cancers. And then there are other much more rare cell types that generally end up being surprises on the biopsy when the pathologist sends you back the final report. Just like a little bit of an aside regarding bronchoalveolar cell cancer, it's undergone kind of like a nomenclature makeover reflecting more sophisticated understanding of the pathology. But basically, it's a spectrum of adenocarcinoma lesions ranging from non-malignant or pre-malignant all the way to frank adenocarcinoma with long names. Atypical adenomatoid hyperplasia, the old-fashioned BAC probably corresponds to adenocarcinoma in situ, and then there are these other increasingly invasive versions. For purposes of this talk, I'm going to call it BAC because it's short. For purposes of reports, I tend to say things like indolent malignancy along the adenocarcinoma spectrum, and then I'll let the pathologist sort it out. This was one of our opening cases, solitary pulmonary nodule. On the CT, it looked like this little spiculated peripheral thing. That was an adenocarcinoma. That's a pretty textbook example of an adenocarcinoma. Peripheral nodule, if the non-smoker is going to get a lung cancer, adenocarcinoma is sort of top of the list for cell types. And the CT screening literature for lung cancer is picking up lots of adenocarcinoma and adenocarcinoma spectrum lesions, so that the percentage of all lung cancers represented by adenocarcinoma is probably increasing as we do more and more of those screens. Here it is on a PET scan, in case you didn't believe me, and that was sort of pre-tracheal metastatic lymphadenopathy in this patient. It's good. Nuclear medicine's wonderful, right? Just a big, bright blob. Squamous cell cancer. This is another sort of classic example of a squamous cell cancer, cavitary, very ugly looking, pretty large lesion, doing some local destruction of some ribs nearby, very heavily smoking associated. This is not any kind of a gospel rule, but they tend to get big locally before they start metastasizing widely. And it may be that squamous cell cancers have the highest mean SUV on PET scans. Another one of our opening images, there it is, a small cell cancer, also a classic appearance, huge mass, centrally located, infiltrating into the hilum/mediastinum, and more or less indistinguishable from the adenopathy that it's contiguous with. This is a different, flavor of lung cancer because it's a neuroendocrine tumor, and the staging is in evolution, and they're sort of trying to get all the staging under one umbrella with respect to lung cancer, but it was that basically the staging for small cell lung cancer takes into account the fact that it's either going to get irradiated or not. And irradiated meant that you could get it all. Limited stage meant that you could get it all into one radiation port. Extensive stage meant you couldn't. And most patients were extensive at presentation. Large cell carcinoma is rare enough that you'll notice the absence of an example in my slides. And it's probably not something to guess about. It doesn't have particularly distinguishing characteristics radiographically, and has, even among lung cancers, a bad prognosis. Here's the lung cancer staging, which I'm sure you all have memorized according to this color scheme. It's, lung cancer staging is complicated, and they've changed it in the relatively recent past. I think breaking down a couple key points is important, but memorizing this chart is not. One key point is the divide between potentially operable cancer and generally inoperable cancer, and that's the stage 3A, 3B divide. And if you sort of look over this chart, you can see there's multiple ways to arrive at those particular stages, but one of the key issues is whether or not you have a T4 tumor. And the way I think about T4 tumors is if the tumor is invading the mediastinum or any of the kind of brand name, big name anatomy structures in the mediastinum, it's a T4 tumor. And the other extra fact to try to maybe cram into your head about T4 is, as of 2009, if there's a satellite nodule in a different lobe in the same lung, that's considered T4 rather than it used to be considered a metastasis, because those patients turned out they were doing a touch better than patients with proper metastases. You can also think of it like this. If they have a colloquial name for the structure on things like CNN, like windpipe or ticker, and there's a lung cancer invading it, it's T4. All right. Lymph nodes, briefly, basically, N1 lymph nodes are ipsilateral hilum or closer to the tumor, out in the lung next to the tumor. N2 is a key divide, and that's ipsilateral mediastinal lymph nodes, including subcarinal lymph nodes. So you can think, subcarinal, you would get the subcarinal lymph nodes for free. That does not upstage you. Every other lymph node is an N3 lymph node. Don't be baited into commenting on N4 lymph nodes. That's inappropriate. And that includes ipsilateral clavicular or scalene lymph nodes. And here's a little bit of a busy slide, but it sort of highlights what I think are the important differences between the older lung cancer staging and the newer lung cancer staging. One of them I talked about, which has to do with the satellite nodules, but the other ones you can review and just keep track of to the extent that you want to. So that covers lung cancer, which is maybe glossed it over in about 9 minutes. Probably inappropriate to finish 9 minutes of lung cancer and say that covers lung cancer. But in any case, it covers lung cancer for our purposes. Everything else is not lung cancer, and I'll go through that. And here you can brace yourself for lots of lists of facts, including differentials, to just let them wash over you and we'll go through it. So what about other malignancies? You look at this case and you're thinking, I'm dealing with metastatic disease. We've got multiple nodules in the patient, very well defined. There's a catheter and some cardiac monitoring leads. But just to broaden the differential, if it's not all metastases, just to have an approach to multiple masses. So Mets are number one, but remember good old-fashioned fungal infection, some mycobacterial infections will give you those kind of 1 to 2 centimeter multiple nodules. Septic emboli is something to keep in the back of your head in the right patient because it's one of those rapidly progressive and needs quick and different intervention kind of diseases to think of, especially if it were cavitary nodules. Organizing pneumonia is on the list for multiple masses, not necessarily going to give you those sharp, well-defined things like the example chest x-ray that I showed. Progressive massive fibrosis I just threw up there because you can't have a talk from chest radiology without showing this x-ray. There's only actually one patient who's ever had progressive massive fibrosis, and this is his x-ray. He was a coal miner, and we all just passed it around. It's like the Stanley Cup. We all get to keep it for a few days out of the year, and then here it is. They gave it to me for this. Or the Olympic torch. I mean, I think either analogy is valid. There it is. It's not the same multiple masses as the first case, but don't forget it. You get showmanship points for talking about progressive massive fibrosis. This happened to be metastatic hepatocellular carcinoma, which causes me to put this round brown ball, which is a cannonball up on your screen in case there was any confusion what that was. So what about a differential for great big Mets, great big round Mets? Colon, renal, testicular, sort of GU cancers. Osteosarcoma will give you the big Mets. This is a case, sort of in the GI-GU category. This was a woman who was asymptomatic, got a thoracic spine x-ray that showed these nodules turned out to be benign metastasizing leiomyoma. All right, this is a film that shows multiple nodules, and you sort of got to look at these things for a while to maybe appreciate this, but the smaller you can see a nodule, if you still see it very discreetly, start to suspect that it's calcified, right? So this big one up in the right lung here, who knows what that is, but wow, there's a tiny one really sharply defined, ditto for this one, which is pretty small. So these are all a bunch of dense nodules, and it gets us into the conversation about multiple calcified nodules. Good old granulomatous disease, old viral infection like varicella. Things that cause calcified sort of perilymphatic nodules like pneumoconioses and amyloid, or more ominous but usually less common things like calcified metastases, things that have bone and chondroid elements in them, chondro and osteosarcoma, or some mucinous adenocarcinomas have been known to calcify. And alveolar microlithiasis gets tacked on at the end because it's an old favorite. It's not quite the progressive massive fibrosis, but we love it so much. This happened to be metastatic osteosarcoma, calcified nodules. On the same neuron, at least in my brain, is the conversation about multiple cystic nodules, multiple cavitary nodules. Here are 2 thin-walled cavitary nodules in the same patient. Carries the differential for a single cavitary nodule, which is squamous cell carcinoma, either primary or metastatic. Metastatic disease from GU cancers. Septic emboli, again, I think it's worth keeping that on your short list of differential items just because it's one of those more dangerous in types of situations. It needs to be treated. Cavitary infections, a possibility like mycobacterial infection. Tracheobronchial papillomatosis, I think I have an example coming up. Let me just talk about wall thickness in pulmonary cavities. So as you would suspect, the thicker the wall is, the more likely it is that the thing is malignant. We use a kind of a 5 and 15 millimeter rule. If it's less than 5 millimeters, it's likely benign. If it's greater than 15, it's likely malignant. But this is another pretty imperfect rule. So for instance, these 2 cases were uterine cancer. Very thin-walled, you might be inclined to use the 5 and 15 rule to say they're probably benign, and that would be reasonable, but turned out to be metastatic uterine cancer. These nodules also thin-walled, turned out to be tracheobronchial papillomatosis. And if that comes up, remember the risk there is transformation to squamous cell carcinoma. Another cavitary nodule, this was fungal infection, pretty thin-walled, but it does have a little bit of you probably get 4 or 5 millimeters out of that oblong. And we're talking about the thickest part of the wall. So it's as innocent as the guiltiest part of the wall. I think guiltiest is a word, by the way. What do we have here? Sort of like the other case where I showed you the tip of the iceberg, but here we have a peripheral endobronchial lesion rather than that central thing that was creeping out into the bronchi. This is another list of differential to have in your head, endobronchial lesions. Don't forget the usual stuff, which is not cancer, mucus and debris, but airway-based squamous cell cancers, metastatic lesions. We've seen breast and colon go to the airways. And carcinoids and hamartomas can be primary within the airways. And then benign neoplastic growths like polyps or strictures. A lot of our patients get lung transplant will get nasty strictures that can mimic actual nodules. These two, carcinoid and hamartoma, might calcify. This patient went on to get this particular nuclear medicine study, which was an octreotide scan, and turned out to be a carcinoid. So that may show up positive on an octreotide scan. Bronchial carcinoid, just a little bit of information there. It's another one of these neuroendocrine tumors that happens in the lungs or airways, tends to be young patients, not associated with smoking, and it breaks down into typical or atypical, where typical tend to be these small solitary endobronchial lesions, pretty much curative by surgery is pretty much curative. Atypical carcinoids can be more out into the parenchyma and can behave more like a proper cancer. And there's a reasonable percentage of them that are FDG negative, so you don't want to take false reassurance from a negative PET scan. Here is another case, multiple irregular peripheral, one might even say flame-shaped nodules. This is one of the opening nodules, opening images. This is Kaposi's sarcoma. These are in patients who usually have skin KS with very low CD4 counts, and they have that infiltrative peribronchovascular flame shape being the key. You either do or don't relate to that descriptor, but that's allegedly their look. And they are treated with a combination of KS-specific chemotherapy and trying to get on top of the HIV. All right, here's a couple of round nodules in an asymptomatic patient. This ends up being a relatively rare diagnosis, which is primary pulmonary lymphoma. Pulmonary lymphoma can be either primary or secondary. Classically, you can see nodules with air bronchograms in them. And the primary lymphoma patients are treated surgically, often asymptomatic, and they're not going to necessarily have a bunch of lymphadenopathy in other compartments. Whereas the secondary pulmonary lymphoma is usually recurrent or refractory lymphoma that's been beaten down a few times by chemotherapy, and then it popped up in the lungs, and it's going to be treated with another round, hopefully, of chemotherapy, and it's usually going to be multiple locations at the same time. So this is a case of a biopsy we did on this lesion, which came back positive for lymphoma. Meanwhile, there was this bulky ipsilateral hilar lymphadenopathy that was also lymphoma in a guy who had multiply recurrent lymphoma coming back on his skin and muscles and all sorts of oddball locations. Brings up the conversation of a mass or a mass-like consolidation in an immunocompromised patient. Think of lymphoma or in solid organ transplant patients, post-transplant lymphoproliferative disorder. Think of KS, I've shown that. Patients who are immunocompromised are more likely to get lung cancer, so think of that. And then things that aren't cancer that are mass-like infections. Another one of our opening cases, big consolidation in the left upper lobe anteriorly, but the key detail here is the asymmetry of the pectoralis musculature. Pectoralis musculature with that arrows showing how the pec is pushed forward. This is one of these chest wall eating consolidations. Your first thought has to be lung cancer, and that would make it a T3 lesion, or some kind of sarcoma that's involving the chest wall and going both in and out. But it's good to keep in the back of your head these infections that have demonstrated an ability to eat their way out of the lung into the chest wall, and that's nocardia, actinomyces, and tuberculosis. And then if somebody's been in there changing the anatomy, then all bets are off. Ordinary stuff can get out into the chest wall and can get in from the chest wall. That ended up being nocardia. Here we go, admission CT, got some pleural effusions, got something that looks relatively aggressive in the left upper lobe, peripheral mass probably at that point. A week later, ready for biopsy. At that point, it's smaller, just eyeballs smaller, and we have all of this diffuse alveolar hemorrhage. This is an oddball case, but throw it in there. This ended up being Wegener's granulomatosis. Turns out that the pleural effusion is atypical for Wegener's granulomatosis. A lot of times has cavitary nodules. The hemorrhage is not atypical. Lymphadenopathy and the pleural fluid are unusual. And this is going to prompt the usual workup into the serological workup as well as checking out the sinuses and renal studies because this is a multi-organ granulomatosis, vasculitis, essentially. I think this is another one of our opening salvo images that maybe that indicating that we're near the end. Something round and well circumscribed in the left lower lobe. 1 week later, air fluid level. This is a good old-fashioned strep pneumonia that cavitated quickly, so rapid evolution tells you you're dealing with something that's likely infectious and inflammatory. Here's another case of a round nodule that was headed for biopsy, came back for the biopsy looking like that. We said, how about we hold off and get another follow-up? Evaporated. So that was a round pneumonia, typically for kids, but it's a possibility in the 30 and 20-year-old crowd as well. Something relatively subtle here besides the pleural effusion. We got something, a left lower lobe opacity or a peripheral left basilar opacity confirmed on the lateral radiographs in the patient with emphysema, getting a CT. We've got the checklist ready for us. We've got to talk about this particular entity in the context of lung masses. Do we have volume loss? Yes. Fissure is pulled back. Do we have a broad base of pleural contact? Yes. Is there an ipsilateral or an adjacent pleural abnormality? Yes. Pleural fluid. Do we have a comet tail? Sure. I mean, that's sort of basically just volume loss with tethering of bronchovasculature. Good old-fashioned round atelectasis. If it's unclear or it's not a home run, it's reasonable to suggest some follow-up. I don't think you're going to have any trouble suggesting follow-up on round atelectasis. Some of them can look like proper masses. Brings up the differential for chronic consolidation. Good old round atelectasis. Bronchoalveolar cell carcinoma can be one of these consolidative type cancers that persists and persists and persists. Organizing pneumonia, you'll see some examples, sort of things that I think of in the category with organizing pneumonia that are less common, lipoid and eosinophilic, and sarcoidosis. This is classic finding of organizing pneumonia, central clearing, incomplete peripheral ring. Again, same patient, different part of the lung. She had dermatomyositis, organizing pneumonia. Related to collagen disease in her case, drug reaction, regular previous infectious pneumonia tipping off this sort of pulmonary overreaction into organizing pneumonia or no good reason. And the classic appearance is this atoll sign with central clearing, but sort of waxing and waning multifocal masses or consolidations should make you think of it over time. How about this? Maybe first glance it looks kind of spiculated and nasty, but there's a little more than meets the eye. There's more of these on the same patient. Ends up being sarcoidosis. And I think the tip-off is the other more typical findings of sarcoidosis when at first you think there's a mass, look for the studding of the fissures and so forth. More examples of sarcoidosis found their way into your syllabus. And finally, just a few benign masses that aren't cancer that tend to come up disproportionately in settings like this and other reviews of cases. 20-year-old getting a stroke, that's abnormal. There's a lobular mass in the right lower lobe. Gets a pulmonary angiogram after the inevitable CT, showing that in fact we have a pulmonary arteriovenous malformation. And the risk, of course, is the stroke, the right to left emboli, infections from emboli, and the sort of loss of the filtering function of the lung, the pulmonary capillary bed. Rupture, less common, but possible. And then there's this bidirectional relationship between pulmonary AVMs and hereditary hemorrhagic telangiectasia, where if you have one, you're likely to have the other. If you have the other, you may have the one. Treated by embolization. Finally, well-defined medial right basilar mass, feeding artery off of aorta. We're into sequestration territory. We either have, what is it sequestered from? The airway and the artery. Forget about the vein. The vein rules are inconsistent. And it tends to be lower lobe. You either have an intralobar sequestration discovered in adults, will be aerated, can get infected, or an extralobar sequestration in babies, often associated with other abnormalities in the baby and fully separated from, by its own pleural envelope. Okay, that's the summary. We've been through it all. Just to review the cases, this was an adenocarcinoma. This was a chest wall eating nocardia infection. This was Kaposi's sarcoma, flame-shaped. Here was a classic small cell lung cancer, and this was the rapidly evolving round pneumonia that got an air fluid level in it.